Great. So I think now we come to the last talk. So Christina, it's always unfair to be the last speaker, but please, people, stay on. It will be a very, very fascinating talk about secondary large vessel vasculitis. I think that's a topic that it's probably not so dealt with. And Christina Ponte from Portugal, and she will talk about this specific topic. And so please be still motivated for the last 15 to 20 minutes.
There's another question from the chat, and it is perhaps a part of the answer to the question is that all imaging is dependent on the pretest probability, Wolfgang.
Okay, yeah, that's sure. That's the point, and therefore I still want to repeat my message. It's very, very important to combine imaging with the clinical appearance, and we should not make the diagnosis of large vessel vasculitis without any clinical evaluation. And well, I'm a clinician, and particularly when we are using ultrasound, it's really one thing. It's the ultrasound is the clinical. The ultrasound is the clinical examination as well. So for me, it's one thing, and therefore the pretest probability is very, very important. And I have my opinion when I start the ultrasound, and that's the same thing.
Okay, so I'll start now. So thank you very much for still being here and for inviting me to just have a lecture on the session called Secondary Large Vessel Vasculitis in Rheumatic Diseases, in particular rheumatoid arthritis. So just have a review with you a brief notion of how you do diagnosis and vasculitis and the entities and definitions you have to have in mind. So when you have a patient that has symptoms suggestive of vasculitis, you always have to see if it could be a primary vasculitis, which are the GCA and Takayasu, for instance, in large vessel vasculitis, and are the vasculitis we are currently talking more in this session. However, there can also be two other things to have in consideration: vasculitis mimics, which are not considered vasculitis because there is no inflammation of the vessels. However, they may have a very similar presentation, and secondary vasculitis, for instance, when we know the etiology of why the vessels are inflamed. This is not, although we have these three divided definitions, they sometimes overlap and they are not very straightforward to divide. Now, considering these three definitions for large vessel vasculitis. So, of course, the primary vasculitis we know of the large vessel vasculitis are GCA and Takayasu, but there are also other primary vasculitis that can also have affection of the large vessel. For instance, Behçet's and Cogan's. We know they can affect the aorta as well as a variable vessel vasculitis. Isolated aortitis without any etiology identified. That is also part of the Sheppel-Hill definition. Also relapsing polychondritis, which is not part of the Sheppel-Hill nomenclature of names. However, it is still a vasculitis and it can affect the aorta. And also AAV and PAN, like we've seen in Professor Wolfgang, in mimics, there can be some cases of ANCA-associated vasculitis that can also have aortitis. So these are the primary vasculitis we have to have in mind when we're seeing a patient with large vessel vasculitis or suspicion of large vessel vasculitis. The problem is when we go to the mimics and secondary vasculitis. Like I said, it's very difficult sometimes to separate between mimics and secondary vasculitis. There are a lot of authors that sometimes use arteriosclerosis here as mimics, other as secondary vasculitis, because it can also have vascular inflammation. And most of the authors actually use these terms together to avoid confusion. However, I try to separate those. I think it makes more sense. So I'm just here reviewing with you the most common mimics you should have in mind when looking at the patient with a potential large vessel vasculitis. So like I said, atherosclerosis is the most common we have to have in mind, particularly for GCA and those older patients. The IgG4 related disease, which is something not as new as like 10 years ago, it started to be talked about mostly 10 years ago, but it also can, although it's a mimic, it can also cause true aortitis, so inflammation of the aorta as well. So it could also be considered secondary vasculitis. Of course, there are all the other hereditary disorders associated to genetics, etc., that we should also have in mind that usually don't have high inflammatory markers like Marfan's and Lardellans, etc. Also, amyloidosis we've seen in Professor Wolfgang Schmidt talk with even amyloidosis giving a halo sign. So Iden-Chester's disease as well, segmental arterial medulosis, congenital aortic coarctation, post-radiation, vascular lesions, very typical, and the thoracic outlet syndrome. But all these are mimics, and you should also have in mind when you're seeing a patient with a potential vasculitis. Now, coming to the secondary vasculitis, which essentially are patients with vasculitis that we know a cause of to how they are, why they have inflammation. So most common infection, and someone asked the session ago if you can distinguish, and it's very difficult, usually with clinical history. You have to know that this could be the agents that can cause inflammation. Also neoplastic vasculitis, and not only neoplastic vasculitis like lymphoma or others, but also treatment with adjunctive treatment in chemotherapy. There are more and more cases that can also give you large vessel vasculitis, and of course the systemic immune-mediated diseases, rheumatoid arthritis, lupus, Sjogren's, myositis, spondyloarthropathies, sarcoidosis, and inflammatory bowel disease. There are case reports for all of these. Of course, my talk will be to focus essentially on those rheumatic diseases that we see the most in clinic. Now, starting with rheumatoid arthritis. So, although we know there is the concept of rheumatoid vasculitis, the rheumatoid vasculitis actually affects more the small and medium vessels in the patient in terms of vasculitis rather than aortitis. However, this association, although very rare, large vessel vasculitis / aortitis with rheumatoid arthritis, is more and more being recognized. It has been described originally in 1936. Since then, and I did a review in PubMed of all the cases I could find with aortitis and rheumatoid arthritis, you can see here, since 1960s, there are several I could find around 29. And you can see that all those patients, when they present with large vessel vasculitis, they're quite old, 60, 61. And don't forget, this is aortitis, so you should have more of a Takayasu pattern, which usually Takayasu doesn't occur above 60 years. Also, they usually present with rheumatoid arthritis first and then vasculitis, not the other way around. Just in 2 cases, I could find that. And they usually have a more severe phenotype of rheumatoid arthritis. You can see here with rheumatoid nodules, positive rheumatoid factor, and TCCP, which was only done in the last cases, the most recent cases, erosions for the ones that were evaluated for that. And also, of course, extra aortic involvement of large vessel vasculitis. So many of these cases not only had aortitis within a rheumatoid arthritis diagnosis, but also had small and medium vessel vasculitis manifesting several times in the skin. So we can see that this was found in an extra aortic arthritis in around 50% of cases. So it's also a clue when you think a patient is unwell, even if the rheumatoid arthritis is under control, but it feels unwell, you start having some changes in the skin. You can also think that it could also have aortitis as well, and do imaging for that. One thing of all the cases I've shown you, the average time between rheumatoid arthritis onset and the beginning of aortitis is around 7 years. And also maybe the cause of that, this is important, because many of those cases I've shown to you, around 12 out of the 29, actually the information was taken by necropsy data. So we have to be aware of that. Unfortunately, there is no specific imaging pattern for these patients that allow us to distinguish between TCA, Takayasu, or rheumatoid arthritis aortitis. This is just an example of a patient I had in my clinic, 48 years old, the rheumatoid arthritis was completely under control with rheumatoid factor and TCP positive, but started with weight loss and high inflammatory markers around 3 years after her diagnosis of rheumatoid arthritis. And you could see here, we asked for a CT, actually at the beginning was even to exclude malignancy, but we could see this thickening around the thoracic aorta compatible with vasculitis, and we started her on high doses of steroids. Also, I'm just showing here another example from our colleagues that published in Japan. A patient with rheumatoid arthritis who was 73 years old that started with cough, upper back pain, and she had a rheumatoid arthritis for 4 years, also seropositive. And you can see here before treatment, she had this thickening of the ascending and the aortic branch. And after treatment, only after 28 days, this thickening almost disappeared. And the same here for PET CT. You can see there's a lot of uptake. And after 42 days, the uptake almost disappears completely. So imaging is also important, of course, for these patients. I also looked at systemic lupus erythematosus. So there is a lot of cardiovascular involvement in lupus. Large vessel vasculitis can also happen and is also indistinguishable between from Takayasu and GCA. And the concept of lupus aortitis is emerging. And usually lupus aortitis occurs with high levels of CRP. We know that in lupus, usually CRP is low, or if it's high, we should suspect infection or psoriasis, but also aortitis could be also a possibility when the CRP starts to increase. Of course, there is a lot of association with lupus aortitis and the development of aneurysms and dissection is significantly increased in comparison to non-lupus patients. Again, there is no specific imaging pattern. This is a review from our Japanese colleagues that look at all cases since 1960s and until now of patients who had aortitis associated with lupus. You can see here that it can affect the whole aorta. Many have the ascending aorta, but it can affect the whole aorta. And imaging, particularly in the last years, has become very important for this diagnosis. And also many progress to develop aneurysm and dissection, which is worrisome and can then have a deadly outcome. Also, this is another case from this same colleague, a 49-year-old case that presented with fever. She had her SLE since she was 14, so more than 30 years. And we can see here also a thickening of the aorta, the thoracic aorta, again. And after treatment, after 21 days with high doses of steroids, she actually decreased this thickening. You can see very well. She has still a bit, but it was decreased. So imaging was important for this. Now, spondyloarthritis. This is the most common rheumatic disease that has some association with large vessel involvement. It's very well known. It can lead to aortitis or periaortitis, vertically and ankylosing spondylitis. The other forms like psoriatic arthritis and reactive arthritis can also have some aortitis, but not so often. One of the characteristics that's very typical of spondyloarthritis is the aortic regurgitation. That it depends on the series and on the years. It has been described in up to 40% of patients with ankylosing spondylitis. Of course, and this involvement of the aorta is usually more common when the disease is more long-standing. So if you have more years of disease, you're more prone of developing this regurgitation. Also, it has been described in almost 2% of patients with reactive arthritis. So this is just an example of a case of a patient having ankylosing spondylitis of our Chinese colleague. You can see here perfectly well this uptake before treatment in the bone marrow and also in the costochondral vertebra, also in the sacroiliac joint, so compatible with ankylosing spondylitis, and also in the same PET scan, you can see here inflammation of the ascending thoracic aorta in frontal and transverse view. And after treatment, almost 2 months afterwards, you can see that this uptake has decreased significantly, as well as here in the ascending aorta. You still can see a bit, but not so severe as compared to the baseline. So questions?
Thank you, Christina. It was very fascinating. You know, it's a topic that it's not so common. Actually, I have a bit of feeling that many of these cases were very historic and a lot from Asia. So do you in your practice nowadays really see these cases. You had one case with rheumatoid arthritis, right? But in lupus or in spondyloarthritis, is that something you see, or is it exceptional?
It's exceptional. I was chasing my rheumatoid arthritis patients because I had that, and actually when I screened him for CT, I was actually thinking of something else. I wasn't thinking of rheumatitis at all. Also, SLE, you can have a lot of cardiovascular manifestations, but mostly vegetation, endocarditis, or things like that. You don't think about aortitis. And like you said, most of those cases, that's why when I use the review for systemic lupus erythematosus, most of them came from Korea, Japan, China. So a lot of those cases there, not here in Europe. There were very few cases, actually. That's why I had to take their images, because I didn't have in my thing.
Okay. Wolfgang, what about the Korean community in Berlin? Do you still see a lot of these patients?
No, not really. So my experience is exactly the same. So our arthritis and rheumatoid arthritis, I mean, we have thousands of rheumatoid arthritis patients, and they just don't appear, at least here. We don't have so many Koreans here, but anyway, it's quite an Asian.
Maybe you are not close enough to Little China in Berlin.
I want to say, if you look at our TCA patients, we have about twice as many patients as we would expect. I mean, both diseases have a certain incidence and prevalence, so it's about a double of that. But the reason is probably, for instance, patients who are anyway within our institution, they may develop giant cell arthritis, we diagnose it here, or they will send more to us. At least in a city like Berlin, it's very distributed. So I think it's just by chance that giant cell arthritis and rheumatoid arthritis do not appear more commonly than they should do from the statistical way here. And so that's what we see is Takayasu with spondyloarthritis. So we have several patients who have both. So I think there is really a relation between not so much to giant cell arthritis, because it's a younger age group. So as we don't see so many Takayasu's, we have quite several. I think I remember about 7, 8 Takayasu's patients with both. So I think there is an increased risk if you have that. But otherwise, I'm not aware of any increased incidence personally.
Okay. I think what, again, your case, Christina, should emphasize again. So when you do a CT scan, ask the radiologist also to look at the vessels. So yeah, that's. I think if you would not specifically look at the aorta, this could be easily overlooked, and the negative result could come back.
Yeah, we sometimes only find these cases when there is a very experienced radiographer that he sees something and then it does the injection for specifically looking at the aorta. And we actually didn't ask, but it depends on the experience of the sonographer as well, and of the radiologist as well. Even our naked eye, sometimes I see, why didn't they report thickening, particularly in patients who are suspected to have GCA, which are 80 years old, They sometimes, I think it's a bit of defensive as well, I understand, because we didn't specify we want to see the vessels. They see thickening in the vessels, but they don't report because they consider it to be arteriosclerosis or part of the arteriosclerosis spectrum, which they also have complications in between. So yeah, I agree. Since like 3 or 4 years ago, I always write, please also check the arteries for this suspicion. In that case, I didn't write because I wasn't expecting to find anything completely other mindset. But yeah.
Okay. Thorsten and Rima, do you see a lot of secondary types of large vessel vasculitis in other diseases?
Rima, do you want to start?
Oh, no, not so many in general. There are exceptional cases with rheumatology and SLE. What we see a lot in oncology is the use of monoclonal antibodies and the temporary existence of large vessel vasculitis patterns. That's what we see many times in the clinic. It's not the CSF so much, but it's more the antibody treatment. You see a really high intense uptake sometimes. Nice examples of that, particularly the treatment in melanoma patients. see little of this exceptional findings, but we see them more often. The combination of rheumatology patients, no, not much. It's exceptional for us.
I agree, and I'd also like to make a point about what Christina said on training. So the radiologist needs to be aware of what he or she is looking at, because it can so nicely be overlooked or so easily be overlooked because it's only maybe 1 millimeter of thickness in the axillary artery, and that even has a course, a vessel course that you maybe want to reformat your images to have an orthogonal view on the vessel, which is easily done, but it has to be done, otherwise you may overlook. And my advice is, as you have said, ask the radiologist specifically what is the thickness of the aorta, what is the thickness of the, let's say, supraaortic arteries. Then they will look, and then they will make the diagnosis for sure. But yeah, the better your question, the better the answer will be.
I think now it's really the time to close. All people are tired. I let you thank the speakers. And
yeah, we are really happy about all your contributions. Many thanks of us for all the speakers, for your brilliant presentations, and also for the enthusiastic discussion and all the input. I think this is really worth to mention it. This is for us a very important contribution for daily clinical practice. And we got a lot of feedback already about that, and many thanks for all the discussion and the brilliant presentations.
So,
okay.
Thanks also to the sponsors. Thanks to all the participants, again, the organizing agency. And
see you all here in Innsbruck in June next year.